Hello everyone. In this module, we'll have a discussion on the approach to the diagnosis of arrhythmias. So if you are an intern posted in the emergency department, you are likely to encounter scenarios of arrhythmias. And as an intern, you are supposed to have a basic skill to identify these arrhythmias. Why? Because arrhythmias are often dangerous and life-threatening. Only if you diagnose it promptly, you can start immediate treatment. So in this module, we'll start off with a discussion on the diagnosis of tachyarrhythmias, followed by a discussion on the diagnosis of bradyarrhythmias. So step number 1 in the diagnosis of arrhythmias would be to determine the heart rate, because arrhythmias can be tachyarrhythmias or bradyarrhythmias. In tachyarrhythmias, the rate is more than 100, and in bradyarrhythmias, the rate is less than 60, right? So how do you find out the rate using the ECG? Now, let me tell you the formula to assess the rate using the ECG. So first of all, you have to see whether the complexes are regular or irregular. If you look at this ECG strip, you can easily identify that the RR interval is regular. So if the RR interval is regular, then you can identify the heart rate by a simple formula. So what is that simple formula? It is 300 divided by number of large squares between two consecutive R waves. Right? So if you look at this ECG strip, which has a regular rhythm, you can see that the number of large squares between two consecutive R waves. So I'm marking two consecutive R waves, between which you can see three large squares. So what is going to be the heart rate here? 300 divided by 3 large squares, which is 100. Okay, this is 100 per minute is the heart rate that is derived from the ECG. Now, what about a scenario where the heart rate is irregular? If the heart rate is irregular, then what you can do is to calculate the heart rate for irregular heart rhythms. You can count the number of R waves over a 6-second period and then multiply that number by 10. For example, if you see, this is 5 large squares. So each large square is 200 millisecond and 5 large square will be 1 second. So this is the next 1 second, the next 1 second, next 1 second, next 1 second, next 1 second. Okay, so you see this is 1, 2, 3, 4, 5, 6. So over a 6-second period, you count the number of R waves. So you can see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, right? There are 10 R waves over a 6-second period. And you have to multiply this by 10. So the heart rate according to this ECG, since the rhythm is irregular, because you can see in this ECG strip, the RR interval is not constant. Okay, the RR interval is varying. So the heart rate here would be 100 according to the formula. Okay, that is what you have got to understand. So once again, to recap, if the rhythm is regular, it is 300 divided by number of large squares. At the same time, you can also apply another formula, which is 1500 divided by the number of small squares, not the large squares, number of small squares between consecutive R waves, and both these formulas essentially mean the same, right? Now, so once you have decided that yes, this is probably a tachyarrhythmia, now you have to see, is it a supraventricular tachyarrhythmia or a ventricular tachyarrhythmia? So these are the two types of tachyarrhythmias, supraventricular and ventricular. So what is a supraventricular tachyarrhythmia and what is a ventricular tachyarrhythmia? In case of supraventricular tachyarrhythmia, the focus of origin of the arrhythmia, remember, the focus of origin of the arrhythmia is above the bundle of His. So let me just mark with green color, the region of bundle of His. You can see it is marked here as well. So the focus of the rhythm abnormality is above the bundle of His. Whereas in case of ventricular tachyarrhythmias, the focus of arrhythmia is below the bundle of His. That's the difference between supraventricular and ventricular tachyarrhythmias, right? Okay. Now, when you have a patient with an ECG strip having a heart rate more than 100 per minute, how do you decide, is it a supraventricular tachyarrhythmia or a ventricular tachyarrhythmia? Please look at the duration of QRS complex. If the QRS duration is less than 120 milliseconds, it is called a supraventricular tachyarrhythmia. And if the QRS duration is more than 120 milliseconds, it is called a ventricular tachyarrhythmias. So you can see, if the duration of QRS complex is more than 3 small squares, it would be a ventricular tachyarrhythmias, and less than 3 small squares, it is likely to be a supraventricular tachyarrhythmia. Now, this ventricular tachyarrhythmia is also referred to as broad complex tachyarrhythmia. Okay, so this is also referred to as broad complex. Since the QRS complex is wide, it is called broad complex tachyarrhythmia, and supraventricular is also called narrow complex tachyarrhythmias. So you've got narrow complex and broad complex tachyarrhythmias. Okay, so that is your first decision step. Is it supraventricular or ventricular? Now, again, you have got to understand, supraventricular tachyarrhythmias can be either regular or irregular. Supraventricular tachyarrhythmias can be regular or irregular. Similarly, your ventricular tachyarrhythmias can also be regular or irregular. Regular or irregular. Right? So regular means regular rhythm, irregular means irregular rhythm. So what are the narrow complex tachyarrhythmias which are regular? Those include, number one, sinus tachycardia. Sinus tachycardia. Sinus tachycardia. You have got paroxysmal supraventricular tachycardia and focal atrial tachycardia. Focal atrial tachycardia and atrial flutter. Atrial flutter. So these are the regular narrow complex tachycardias. Whereas the irregular narrow complex tachycardias include the multifocal atrial tachycardia, multifocal atrial tachycardia, and atrial fibrillation. And atrial fibrillation. Okay. So let's try to see them one by one, the narrow complex tachyarrhythmias. Okay. Right. So I think we'll start off with an ECG here. So if you look at this ECG, you can see that the heart rate from this ECG, as I told you, 300 divided by number of large squares. So almost you have got 2.5 large squares. So the heart rate comes to around 120. So from this ECG, the heart rate is around 120 per minute. So definitely there is a tachyarrhythmia. Now you have got to decide, is it a narrow complex or broad complex? If you look at the ECG, you can see that the QRS is narrow. It is not more than 3 small squares. So you've got a supraventricular tachyarrhythmia here, right? So once you have decided it is a supraventricular or narrow complex tachyarrhythmia, now you have to see, is it regular or irregular? So what is happening here? You can see that the RR interval is regular. Yes, here you have got a regular RR interval. So you are dealing with a regular narrow complex tachyarrhythmias. Now, once you get a regular narrow complex tachyarrhythmias, what should you do to come to a conclusion? Now, if you get a narrow complex regular tachyarrhythmia with a normal morphology P wave followed by a QRS complex, then you are dealing with a sinus tachycardia. So look at this. For each of the QRS, you can see preceding there is a P wave, and all these P waves are normal morphology, correct? You have got a normal morphology P wave preceding every QRS complex. So when you get such sort of a normal morphology P wave, that's a key word. So a regular narrow complex tachyarrhythmia with a normal morphology P wave, preceding each QRS. What is the diagnosis? The diagnosis is sinus tachycardia. The diagnosis is sinus tachycardia. So this is a sinus tachycardia, right? So that's clear, and we are settled for this. Now, let's have a look at the next ECG. So next ECG, you can see that we are again dealing with tachyarrhythmia. You can see that it is almost, say, 1.5 large squares between the consecutive R waves. So we are again dealing with a tachyarrhythmia. So once you decide that it is a tachyarrhythmia, the next step would be to look at the QRS complex. And here again, it is a narrow complex. So once you have, a decision that it is a narrow complex tachyarrhythmia, next step is to see whether it is a regular narrow complex or an irregular narrow complex. So this would be a regular narrow complex tachyarrhythmia. Now, once you decide it is a regular narrow complex tachyarrhythmia, what is the next step? Please look at the P wave. Now, do you have a regular morphology P wave here? No. What are you having? You are having absent P waves. Are you seeing any P waves? No. So if you see, remember, if you have absent P waves, it is again, remember, a regular narrow complex tachyarrhythmia with absent P wave. Then you will be thinking of the diagnosis of paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia or PSVT. Okay, remember, absent P wave. Okay, that is clear. Now, let us discuss the next ECG. So the next ECG that we are going to discuss, let's have a look at this ECG. Now, what is unique about this ECG? If you look at the rhythm strip of the ECG, that is the long lead 2, you are seeing that, yes, you have got the heart rate of around 100 per minute here. So it is again a regular narrow complex tachyarrhythmia. And once you have identified it is a regular narrow complex tachyarrhythmia, the next step is to look at the P wave morphology. Now, when you look at the morphology of P wave, well, you are getting an abnormal morphology of the P wave. Yes, it is inverted. You can see in all the inferior leads, the lead 2, lead 3, okay, the lead AVF. So in all these inferior leads, you have got the P wave being inverted. So you've got inverted P wave, but if you scan through the entire rhythm strip, you can see that all the P waves are appearing similar. Okay, all the P waves are appearing similar. Now, just that the P wave morphology is abnormal, you're quite sure that it is not a sinus tachycardia. Because if the focus was from the sinus node, you would have had a normal morphology P wave. And if it was a PSVT, you would have had a absent P wave, right? But here you are seeing a P wave of an abnormal morphology and all the P waves look similar. So what is this ECG known as? This is the ECG of a focal atrial tachycardia. So what is happening in focal atrial tachycardia is there is a single ectopic focus within the atria but outside the sinus node. It is supraventricular, but the focus is anywhere outside the sinus node. So what is going to happen? You're likely to have an abnormal P wave morphology, but all the P waves will be identical. Okay, and the QRS morphology also will be normal. So this is what is called a focal atrial tachycardia. Okay, focal atrial tachycardia. Got it. Now the next ECG that you should know is this one. Now if you look at this ECG, sometimes you might not identify this to be a tachyarrhythmia at first glance, because when you look at the ventricular rate here, mind you, the ventricular rate, you might find it's 4 large squares between the R waves. So 300 divided by 4, it would be 75. So you might think that we are not at all dealing with the tachyarrhythmia, but you have got a problem here. Remember that though the ventricular rate is normal here, I want you to look at the atrial rate. So the atrial rate between the subsequent P waves, you can see certain abnormal morphology P waves are here. And if you look at the atrial rate, that is between the two P waves, it's just one large square. So you tell me what is the atrial rate here. The atrial rate here is 300. Okay, so the ventricular rate is only 75 per minute, but the atrial rate is 300. Okay, so this is in fact a tachyarrhythmia. And what sort of tachyarrhythmia? See, once you look at the P wave morphology, you will find that the P wave morphology is a sort of sawtooth pattern. So you've got a sawtooth morphology of the P wave. Sawtooth morphology of the P wave. Okay, and not just that, see, when you look at this discrepancy between the atrial and ventricular rate, you will understand that, see, you've got atrial rate of 300 and ventricular rate of 75. So there is a sort of AV block here. That is why all the atrial impulses are not getting conducted to the ventricles. So what you are having here is an arrhythmia that is known as atrial flutter. And atrial flutter is often associated with AV block. Okay, AV block. So let us see what is an atrial flutter. Atrial flutter, you are likely to have a regular atrial activity at around 300 beats per minute with a sawtooth pattern of P wave, and the ventricular rate is often decided by the AV conduction ratio, which might be 2:1, 3:1 or 4:1. You can have any of these ratios. Now here in the ECG, we are having what sort of an AV block? It is 4:1, because only after every 4 P waves you are having a conducted QRS complex, correct? So this would be a 4:1 block. And another finding you should note is that in atrial flutter, you are not going to see an isoelectric baseline. So there is a loss of isoelectric baseline. So the complete diagnosis to this ECG, it's an atrial flutter with 4:1 AV block. Okay. So most common type of AV block associated with a flutter will be a 2:1 AV block, but here we have got a 4:1 AV block. Understood? Right. So that's it. We have discussed about the supraventricular tachyarrhythmias, which are regular sinus tachyarrhythmia. We have seen the paroxysmal supraventricular tachycardia, focal atrial tachycardia, and atrial flutter. Now coming to the narrow complex irregular tachyarrhythmias. So let's have a look at this ECG. Okay. So if you have a look at this ECG, yes, there is a tachyarrhythmia. Okay, there is a tachyarrhythmia, and it is a narrow complex tachyarrhythmia. And when you get a narrow complex tachyarrhythmia, please see if it is regular or irregular. So what is this? You can see that the consecutive R waves, you can see that they are not regular. There is a definite irregularity. Okay, so you're either dealing with a condition like multifocal atrial tachycardia, or you are dealing with a condition like a atrial fibrillation. So how to identify? Again, next step is to look at the P wave morphology. When you look at the P wave morphology, let's see the P wave morphologies here. If you scan through the P waves, you can see that the P waves are having abnormal morphology, and not just that the P waves are looking different. Okay, so the focus of arrhythmia is not one. Because the P wave looks different, you have got multiple foci of the arrhythmia from the atria. Okay, so what is this condition known as? It's called a multifocal atrial tachycardia. So in a multifocal atrial tachycardia, the heart rate would be more than 100 beats per minute with an irregular rhythm, and you will have at least 3 distinct P wave morphologies in the same lead to confirm the diagnosis. Okay, so that would be a multifocal atrial tachycardia, right? So that diagnosis is also clear. So coming to the next ECG. So the next ECG that we are dealing with again is a narrow complex tachyarrhythmia, but again you can see the RR interval is varying. So here also we are dealing with a narrow complex irregular tachyarrhythmia. So it's either multifocal atrial tachycardia or atrial fibrillation. But if you look at the P wave, are you able to make out definite P wave? No, you are not able to make out definite P wave, and all what you are able to make out is the presence of certain fibrillary waves. So the P waves are absent, you are having some fibrillary waves. So either you will have a relatively flat baseline, or you may have some sort of a fibrillary waves, and you are seeing fibrillary waves here. So we are dealing with atrial fibrillation, where you get an irregular rhythm with no P waves, but fibrillary waves are present, and there is an absence of isoelectric baseline. So this would be atrial fibrillation. Okay, right. So we have discussed all the supraventricular tachyarrhythmias, and what are the regular ones, what are the irregular ones. Let's now discuss the ventricular tachyarrhythmias. Now, the hallmark of ventricular tachyarrhythmias is a broad QRS complex. So broad QRS complex, why? Because in a ventricular tachyarrhythmias, you do not have a simultaneous activation of ventricles. See, why in supraventricular tachyarrhythmias you are still having a narrow QRS complex? Because still in these arrhythmias, in supraventricular arrhythmias, both the ventricles are being activated simultaneously. So you have got a normal QRS complex duration. But here, if the foci is, say, within the ventricular muscle or Purkinje fibers, usually one side of the ventricle gets activated first and then the other side of the ventricle, and you will get a broad QRS complex. Okay. Now, ventricular tachyarrhythmias can again be regular or irregular. Regular or irregular. Now, a regular ventricular tachyarrhythmia and irregular tachyarrhythmia. A regular ventricular tachyarrhythmia is likely to have similar morphology of the QRS complex, which is called a monomorphic VT. Okay, the morphology of the QRS complexes will be similar. It's called a monomorphic VT. And an irregular one is likely to have varying morphology of the QRS complex, which is called a polymorphic VT. So if you look at this ECG, so this one, very obvious, you can see that the QRS duration is wide. So you have got a broad QRS. Okay, so this is a broad QRS. You can see that the QRS duration is definitely wide. So broad QRS complex you are having. So broad QRS complex, and if you look at the morphology of the QRS complex, all of them are having a similar morphology. So what is going to be the diagnosis here? This would be a monomorphic ventricular tachycardia. Monomorphic ventricular tachycardia with similar morphology of the QRS complex. Whereas the next one again is a broad complex tachyarrhythmia, which is irregular. And when you look at the QRS morphology, you can see it is a varying QRS morphology. So this will be a polymorphic ventricular tachycardia. Polymorphic ventricular tachycardia. And remember, the problem with ventricular tachycardias is that they can degenerate into ventricular fibrillation. So when it goes to ventricular fibrillation, unlike the ventricular tachycardia, you will not be able to appreciate definite QRS morphology. Okay, you will have a sort of fibrillations there, and the definite QRS morphology cannot be appreciated. So especially these polymorphic VTs are more likely to degenerate into ventricular fibrillation. Okay, right. And one more ECG you should know. This again is a type of polymorphic ventricular tachycardia, but a unique feature is that there is some sort of an oscillatory change in the amplitude of QRS complex. So this sort of an oscillatory change in the amplitude of QRS complex, it's called, twisting of the axis. It goes above the baseline, then it below the baseline. So this sort of a twisting of the axis is referred to as torsades de pontis. Okay, it's referred to as torsades de pontis, which is a type of polymorphic ventricular tachyarrhythmia. Okay, so thus in this module we have discussed the approach to tachyarrhythmias, a very simplified approach. Let us now discuss about the approach to the diagnosis of bradyarrhythmias. First of all, you should know the classification of bradyarrhythmias. So bradyarrhythmias can occur due to either a sinus node dysfunction or due to AV conduction abnormality. So what are the bradyarrhythmias that occur due to sinus node dysfunction? You have got the sinus bradycardia, the sinus pause, also known as sinus arrest, the sinoatrial exit block, and the tachycardia bradycardia syndrome. And then you have got the AV conduction abnormalities, which can again be divided into first degree AV block, second degree AV block, and a third degree AV block, right? Okay. So let us see the approach to the diagnosis of these bradyarrhythmias. So we'll first discuss about bradyarrhythmias that occur due to sinus node dysfunction, followed by a discussion of bradyarrhythmias that occur due to AV conduction abnormalities. So let's have a look at this ECG strip first. So if you look at the heart rate between the consecutive R waves, you can see that there are almost 6 large squares. So what is going to be the heart rate? The heart rate is going to be 300 divided by 6, 300 divided by 6, which would be 50 per minute. So we're dealing with a bradyarrhythmia. Now if you look at each of the QRS complex, each one of them is preceded by a P wave with normal PR interval. Can you see them? It's a normal P wave and a normal PR interval. So PR interval normal means there is no AV conduction abnormality, and since the sinus node is normal, you are getting a normal morphology P wave. So what is this referred to as? This is the sinus bradycardia. This is the sinus bradycardia. So what are the characteristic ECG features of a sinus bradycardia? So number one, you've got a heart rate less than 60 per minute with a sinus rhythm. So the P waves have got a normal contour and occur before each QRS complex with a constant PR interval. So this is what you should know about sinus bradycardia. Okay. Now let's come to the next ECG. So if you scan through the ECG that you're seeing on screen now, you are seeing a normal P wave followed by QRS. Again, normal, normal, normal. But following this, you're not seeing the P wave. And not just the P wave, you're not seeing the ventricular depolarization as well. Well, you're having a period of pause. And this is a sinus pause. And why do I call it a sinus pause? There is a failure of the SA node to discharge. And you can very well notice that for the complexes that are there in the ECG, the PR interval is normal. So PR interval normal means AV conduction is normal. So what is this condition known as? This is a sinus pause or sinus arrest, which is characterized by a failure of the sinus node to discharge. And because of that, there is no atrial depolarization. And not just that, during that period, there is no other pacemaker that is taking an upper hand, because of which there is a period of ventricular asystole as well. So this is a sinus pause or a sinus arrest. Okay, right. Now, coming to the next ECG. Coming to the next ECG, if you scan through this, it looks very similar to the previous ECG that we have discussed. You are seeing a period of sinus pause, aren't you? But what is unique about this sinus pause compared to the previous one? Well, if you look at this pause, you can almost imagine that there is actually a probable PQRST that could have fit in exactly in this time frame. Yes or no? So what is the possibility? The possibility was, in fact, the sinus node had discharged. But then what happened? Well, we have got a condition known as sinoatrial exit block, where the impulse is formed in the sinus node, but it fails to conduct to the atria. Okay, so that means the depolarizations cannot leave the SA node towards the atria. And how do you identify this sinoatrial exit block and differentiate from a sinus pause? Well, here the pause is a multiple of the PP interval that preceded the pause. That is how you will be able to identify a sinoatrial exit block. Okay, right. Now coming to the next ECG. Now if you scan through this ECG, you can see periods of pause, no doubt about it, and periods of tachy as well. So I've got brady and tachy in the same ECG, right? So what is this known as? This is called tachycardia bradycardia syndrome. So in a tachycardia bradycardia syndrome, you are having episodes of tachycardia and bradycardia. Okay, so this tachycardia can either be an atrial fibrillation or an atrial flutter or an atrial tachycardia. And upon termination of these atrial tachyarrhythmias, you can have a period of prolonged sinus arrest or asystole. Okay, this is called tachycardia bradycardia syndrome, right? Okay. So after having discussed about all the sinus node dysfunction, remember a symptomatic sinus node dysfunction, what would you call it? You will call it the sixth sinus syndrome. Sixth sinus syndrome. Okay, right. Now we are going to discuss about the next group of bradyarrhythmias that occur due to AV block or the heart block. So what happens in AV block is that the atrial impulse is conducted with a delay, okay, or is not conducted at all to the ventricles, okay. That is what is an AV block. So AV block can be first degree, second degree or third degree. So what is happening in a first degree AV block? So in a first degree AV block, if you look at this ECG, you can notice that the PR interval is prolonged. So the PR interval more than 200 milliseconds, you would call it to be a prolonged PR interval, and you are having a constant PR interval prolongation. So all the PR intervals are prolonged. You have got a constant PR interval prolongation. So this is called a first degree AV block, where in fact all the atrial impulses are conducted to the ventricles, but the PR interval is more than 200 milliseconds, and that is what you call a first degree AV block. Okay. Now, what is a second degree AV block? In a second degree AV block, unlike the first degree AV block, all the atrial impulses are not conducted to the ventricles. So what does that mean? Look at this ECG here. So here you can see that the problem is with the PR interval. Okay. So you can see that there is a prolongation of the PR interval. There is a gradual prolongation of the PR interval, and then you can see there is a non-conducted P wave. Correct? And following a period of pause where you have got the atrial depolarization, but there is no subsequent QRS complex, and then again the P again appears, and this again is characterized by progressive subsequent prolongation of PR interval and then a non-conducted P wave. What is this phenomenon known as? This is known as Wenckebach phenomenon. Okay, this is called Wenckebach phenomenon, which is a progressive prolongation of the PR interval followed by a non-conducted P wave, and this happens in a second degree AV block, Mobitz type 1. Okay, a progressive prolongation of PR interval followed by a non-conducted P wave. Okay, right. Coming to the next ECG. So if you scan through this ECG, what are you seeing? You can see that yes, the P waves are getting conducted, but you can see that this particular P wave is not getting conducted, and the subsequent P waves are also getting conducted with a normal PR interval. Correct or not? So the preceding as well as succeeding P waves are conducted with a normal PR interval, but in between this P wave is not getting conducted. So this is called a second degree AV block, Mobitz type 2, where you get non-conducted P waves just like second degree AV block Mobitz type 1, but here you are not having any progressive prolongation of the PR interval. This is second degree AV block Mobitz type 2, right? Okay. Now this one is another special variant, which you can see is a 2:1 AV block, where the alternate P waves are not conducted. Okay, so you can see that this P wave is conducted, this P wave is not conducted, this P wave is conducted, this is not conducted. So a 2:1 AV block, it's very difficult to say whether it is actually a Mobitz type 1 or Mobitz type 2. It can either be a Mobitz type 1 or a Mobitz type 2. Okay, so this is called a 2:1 AV block. Okay, similarly you can have a 3:1 AV block like that. Okay, right. Now coming to the next ECG, just look at the ECG on screen. What are you seeing? Look at the P waves, look at the QRS complexes. So this is a P wave, 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 P wave, P wave, P wave, P wave. And you've got the QRS complexes. Okay, so what is so unique about this? Look, the PP interval is constant, the RR interval is constant, and the PR interval is varying. So you've got a constant atrial rate, a constant ventricular rate, but the atria and ventricles are dissociated. You've got varying PR interval. Okay, so this happens in case of a third degree AV block where the atria and ventricles will beat independently. There is a complete AV dissociation. So the ventricular activity hence is actually maintained by an escape rhythm arising in the AV node or bundle of His. In that case, you would have a narrow QRS complex. But if the escape rhythm is originating from the distal Purkinje fibers, it would have a broad QRS. Okay, so in a third degree AV block, depending on the site of the escape rhythm, you can have a narrow or a broad QRS complex. So that is how you will differentiate, you'll identify a third degree AV block. And remember, this third degree AV block is also referred to as a CHB, that is a complete heart block. Okay, it is also referred to as a complete heart block. Okay, complete heart block. So this is how you will differentiate the various type of bradyarrhythmias.